Yeah, somebody in the audience said they can hear.
Just go ahead with it.
Okay.
I can invite you. I can hear, I can hear.
No audio.
Recall.
Should I go?
Yeah, just go ahead and talk.
Okay. Hi, everybody. Thank you for having me here. Always a pleasure. And thank you, Gary, for the introduction. Today, we'll be talking about the support of the hypoxic patients with COVID-19 pandemic. My name is Ihab Dawood, and I'm associate professor at JAPSOM in University of Hawaii, and co-founder and currently the president of the new Society of Mechanical Ventilation that Gary mentioned. I have no conflict of interest in this talk, and I hope it could be beneficial to everyone. So my question is, we're going to start. It's since the pandemic started back in December 2019, so almost about 2 years, less than 2 years. What we have learned in this last 2 years, are we better than we were 2 years ago? And here is the whole answer. Nothing. I don't think we really learned much. And by that, I will end the lecture. Thank you very much. Any questions? Okay, just joking. It will be much nicer. But pretty much what I'm going to be talking about, the confusion that we are all in. Not here only in the States, all over the world. So basically, how do we take care of the COVID-19 patients? When the pandemic started, it started in China, and we thought it was going to stay in China. It's China's problem. Unfortunately, January came, March, and started all over the world. What made me kind of like upset or angry, to be honest with you, is a couple of societies came with some guidelines back in March 2020, when we didn't really have much studies. We don't know much about that disease or how to deal with it. So the Society of Critical Care Medicine and the European Society of Intensive Care came with these guidelines in the surviving sepsis. And pretty much I put those 3 points. They said early intubation, because that can help in infection control. Use the ARDS network strategy for ventilation, low tidal volume, high PEEP, according to the PEEP-FI tool table, and do not use any steroids. The reason, as I told you, made me angry is those are based on no studies about COVID. We just used our knowledge from regular ARDS and start applying it in COVID. And in my mind, at least, that probably why our mortality was so high earlier in the pandemic. So if you look at this slide about the pathology, even till now, we're not sure about the pathology of COVID. Is it similar to our regular ARDS? The answer is probably not, or maybe it's sharing some of the pathology. Some people talked it's similar to pathology of high altitude pulmonary edema. A lot of other people said no. Then started the talk by Gattinoni group in Italy and Germany last year about there might be different phenotypes of COVID-19, and they called it the L and the H, and we'll talk about it a little bit. L is the low compliance and H is the high compliance. Even then, what's the inflammatory status of the patient? It's is it a hyperinflammatory status or a hypo-inflammatory status? Should we ventilate the patients as the usual ARDS, as we talked about? Or if we use that strategy, could it be harmful? And probably the answer is yes. If you look at this graph here, I know part of it is kind of hidden, sorry. Thank you. We'll start as like the beginning of the onset of symptoms. The PaO2 might be low. It started the inflammatory shunting, some edema and atelectasis, not as bad as our usual ARDS. Loss of lung perfusion regulation, the VQ mismatch, which happens much earlier. along with intravascular microthrombi and thrombosis. These are all sometimes before even the patients start to become dyspneic and come present to the hospital or ask for care. And as the disease progresses by time, we start seeing reduced lung compliance, increased dead space, increased consolidation on X-ray and CT scans, CO2 retention, and usually ends up by fatigue and the need of mechanical intubation. So the disease in COVID-19, just to summarize, is not one stage of the disease like ARDS. You have septic shock and you start by bad compliance of the respiratory system, consolidation, response to PEEP. No, here is different. Matter of fact, earlier in the disease, I will see some X-rays and some CT scans. It's not that bad. Good respiratory system compliance. It's a ventilation perfusion. Perfusion plays a big role here. And again, that slide talks about like role of medical treatment, like antivirals, anti-inflammatory medications, anticoagulation, lung protective ventilation. In this lecture, I'm not going to talk about any medical therapy. We're just going to stick with the ventilatory strategies or support for the patient, the hypoxic patient. So again, the confusion in the pathology. Those are a couple of, I picked those articles because they address that issue. Is COVID-19 pneumonia, is it ARDS or not? And I put some of the references here. Another one from the American Journal of Respiratory Critical Care states COVID-19 does not lead to your typical ARDS. So we should not support those patients or ventilate them as the regular ARDS, what we're used to. They describe three distinctive angiocentric features of COVID-19. As I said, initially in the disease, the most problem is perfusion. So number one starts with severe endothelial injury associated with the virus that disrupts the endothelial cell membranes, followed by wide vascular thrombosis. And when you have those microthrombosis, you're worsening the ventilation perfusion mismatch and the dead space, which is like almost 9 times higher than the regular ARDS from bacteria or from shock that we're used to. Then followed by significant new vessel growth angiogenic features more than ARDS. So the point that I really want to make is COVID-19 respiratory failure might be different than the ARDS. I want to really stress on that. And we should not deal with it as the regular ARDS that we have lots of studies about. Another slide about the phenotypes, the L and the H. So if you see here, this is the regular ARDS we're used to in the top left corner with very high consolidation, as you can see, more than 75%, and very low compliance. So the x-axis is the compliance in milliliters per centimeter water, and then the y-axis here is the amount of consolidation. So this is the ARDS we're used to. Versus this is usually the COVID that we've been seeing. X-rays, CT scans don't look that bad. Those people compliance very high, described as more than 50. And honestly, in my experience, I had to intubate patients. I have difficult time to oxygenate them. And I'm calculating the compliance, it's like 50 or 80. That's pretty much almost normal. And it's like, why can't I oxygenate people who have great compliance? We usually extubate people even at much lower compliance than that. And some other discrepancies, but you can see like the curve here. Here is a person with very high consolidation, here 50 to 75%, but his compliance is high, which doesn't make sense when you think about it normally. So again, we'll talk about continue talking about the confusion. One of the very important questions is, when do we intubate the patients? And I really struggle with that question. I think we used to think about intubating the patient and starting mechanical ventilation. It's pretty much death sentence for the patient with COVID. And there might be truth to that too. Initially, our mortality on mechanical ventilation was very high, about 70%, take or give. So when that, again, when it started, the pandemic, most of the guidelines said intubate them early because you reduce the risk for contamination and infection to staff and other patients. Then as we progressed through the pandemic, we discovered that we might be short on ventilators, so we can't intubate everybody with hypoxia from ARDS. We were very scared about high flow and nasal cannula and inhalers and non-invasive positive pressure ventilation. Then came a group of people start saying, you know what, those people are hypoxic in the 70s and 80s, but they're doing fine. They're what we call them happy hypoxic. It's okay, just leave them like this as long as they're mentating, they're perfusing, which always made me like kind of like, are they really happy? Can we keep somebody saturating 75, 80% with no injury? Then came the other big debate and the hot topic, which something called PSILI, patient self-induced lung injury. Yes, we can keep those people even there if we start to oxygenate them at saturation 92 or 90 or 94 with the high flow or with the non-invasive. Are we doing them any favor, keeping them breathing 30, rate of 30, 35? They're always, if you see them, their respiratory drive is very high. There are a lot of pleural pressure swings, a lot of lung injury. And eventually, if you see those people who stay in the high flow and the non-invasive for a week or two, at least from my personal experience, they still end up on the ventilator. Is it the virus kept progressing or the patient, we let them induce lung injury, self-induced lung injury? So that's very important. So again, the question is to try to not intubate them to rush into ventilation with our limited resources, and at the same time, not leave them, the patient, to suffer and cause lung injury. Then when we intubate them in a very late stage, becomes very confusing. And again, I still struggle with that. Is it clinical, like according to hypoxia, tachypnea, dyspnea? Probably, I think in our stage, I think it's still a clinical decision. There's a couple of indexes. One is called ROX index, widely, and they pick, I think, a number of less than 4.5. I'm going to show it here. That might help you a little bit to see. And that index was studied on people who might fail the high flow nasal cannula. Excuse me. Okay, let's go to another confusion, which actually the ventilator shortage. In the beginning of the, again, in the pandemic, we discovered that we are not actually equipped as the whole world to deal with a pandemic. People started in the social media posting that, oh, you know, we're short of ventilators, so we can split the ventilator into two and ventilate 2 people. And if you see those 7 societies here immediately came back in March after those social media videos and YouTube and stuff, and totally condemned this process. They said, no, don't do it. It's attempting to ventilate multiple patients with COVID, could lead to poor outcomes, high mortality rate. And it's better to purpose the ventilator to the patient most likely to benefit than one to fail. That actually make me really, really uncomfortable. The idea of rationing our resources. I think what made me really actually more angry is, if I was one of those societies, I would say, yes, we have a ventilator shortage. So let's help you clinicians to do this in a safe way. Let's see what the issues, what can lead to mortality or harm, and let's address it, and let's help, you know, because this can pretty much double our resources. And to be honest with you, that's what made me starting, like, you know, the Society of Mechanical Ventilation and the Journal of Mechanical Ventilation. I know I'm advertising it, but you will see it on the top right corner here. I put this, and that's basically, we started that as like to get ideas from all the clinicians, to help clinicians to start a new platform and everything free to help people who are confused like us. I didn't put that next slide, but at the same time, after months of this guidelines, the FEMA came and said, you know what? Yes, it's not optimal to put patients on split ventilation, but it could be done. And they put great resources how we can do it a little bit safer. Of course, it's not the standard. I don't think we should do it standard. But as a clinician, I can't really decide, sorry, you are gonna die, so I'm not gonna offer you a ventilator. You might have a chance, so I'm giving you the ventilator. That's kind of playing God, and I did not like that. So our first issue of the journal came in June, and we did a study to do split ventilation. We're not the only ones who did that. Actually, in Hawaii, there's other group who did it. There's multiple groups all over the country that worked to try to do this as safer as possible, to give everybody out of those two patients the tidal volume they need, the PEEP they need. So try to do it in a safe process. All right, let's continue the confusion. Ventilator strategies. As I told you before, the Society of Critical Care Medicine said, and they're still sticking with, use the ARDS network strategy, the low tidal volume PEEP. And as I will show you before, that I'm sorry, in the next slides, that might not be the best thing to do. This is the L phenotype with low lung recruitability, so they might not benefit from recruitment maneuvers. They have high compliance, so they might not benefit from PEEP. Matter of fact, high PEEP can worsen their compliance, worsen the VQ mismatch, and they have low lung weight and low VQ mismatch. And putting them on the ARDS ventilator strategy with, as we talked about, might actually cause, I know it's very complicated, I don't want to go through this whole diagram, but basically, we might be causing cardiovascular instability, acute lung injury, worsening hypoxia. And this is the H phenotype, that they have high lung weight, high recruitability, so high right to left shunt and low compliance. So those are the people that might benefit from PEEP and recruitment maneuver and proning and all this stuff. So again, should we use the ARDS network strategy? And again, this is just a personal opinion, is no. High or low PEEP. Timing of the disease. So the patient doesn't mean in the beginning he started with high compliance and didn't benefit from PEEP, doesn't mean the next week he shouldn't. And the end point of my talk would be that should be personalized. Mechanical ventilation, whether in COVID or non-COVID, should be personalized to the patient. It can't be that one head fit all. Even ARDS, some people benefit from recruitment and proning and everything, and some others don't. Same with COVID. We are not all the same. So one strategies would not work. You have to spend time with the patient. Of course, in the pandemic, when one clinician, whether a respiratory therapist, physician, taking care of 20 hypoxic patients or 30, spending 1 or 2 hours trying to do all this VP curves and esophageal balloons and proning, it's almost impossible to do. So it's a very unfortunate situation, and I think that contributed to our high mortality. Now we're going to show you a case happened to me personal, actually about 10 days ago. This 36-year-old male, very healthy, no medical problems, unvaccinated, unfortunately, was diagnosed 6 days before he came to the hospital. Came to the hospital in the emergency room, saturating 78%, really just a little dyspnea, but nothing bad. Was started on all the medications that we give, remdesivir, decadron, tocilizumab, which is interleukin-6 inhibitor. Day 1, he was on 6 liters, just regular low flow nasal cannula, was doing okay. Second days, keep getting more hypoxic. So now he's on high flow nasal cannula, 100%, 60 liters per minute. When you ask him, how are you doing? I'm doing okay. But the patient's breathing 30, a little bit tachycardic. Are you okay? You sure you're okay? Yes, I'm doing okay. Talking on the phone. Okay, cool. We'll stay the course. Day 3, now the patient's more hypoxic on the high flow. 60 liters per minute, 100%. We add 15 liters nasal non-rebreather mask on top, which to be honest with you, I'm not sure what does it do. But now his respiratory rate is in the 35, his heart rate is going up 110, 120. His oxygen saturation barely making the 88 to 90%. Talk to the patient, of course, he's scared of being intubated. Talk to his wife on Zoom, talk to his sister on Zoom. Everybody's scared, but we came to the conclusion, listen, we watch you 3 days, you are definitely progressing, you're going in the wrong direction. I think we should not let you become emergent and we intubate you while you're almost coding or dying. He agreed, and we're just about to do it. Everybody in the team, we're wearing our protective gear, 3 respiratory therapists waiting to help with everything. Rush the pulmonologist on the case and the hospitals, no, don't do it. Don't do it, he's doing okay. He's saturating 88%, he's still talking. His D-dimers and C-reactive protein and all this are coming down, he should be okay. Kind of frustrated, and what do good, nice doctors do when they get frustrated? I did same. I signed off the case. And I said, okay, you know what? Let me know if you need me anymore. But I tried not to interfere or cause more problems or give the patient and the family mixed messages. Day 5, 2 days later, the patient 75%, he's very dyspneic, very tachycardic, sweating, and the patient gets emergently intubated. And I get called after the patient is intubated because his oxygen saturation is still in the 70s. You can't oxygenate him. Spent 3 hours trying to get to a strategy where we can oxygenate the patient. We tried the recruitment maneuvers, we did the pressure volume curves to see what the best PEEP. We put an esophageal balloon to try to see what the best PEEP. We prone the patient, paralyzed. We did everything in the book. Interesting, I actually forgot to tell you, this is the X-ray, as you can see it here. Not that bad, right? You shouldn't expect that patient should be very hard to oxygenate. They did a CT to rule out pulmonary embolism, which is reasonable because pulmonary embolism is almost 9 times higher. Not much, negative pulmonary embolism, but you can see the ground glass. Not much consolidation as the ARDS, but the diffuse ground glass alveolar filling. When we do the recruitment maneuvers on the high PEEP, you can see the patient oxygen saturation, matter of fact, going to 50%, almost the patient about to code because I increased the PEEP. And the only way, believe it or not, to oxygenate the patient to the best I got was 85%, was a PEEP of 4 to 5, with high tidal volume, much more than 6 milliliter per kg. Just to buy myself time to call the tertiary center to get him in the ECMO. Unfortunately, ECMO is not widely available. And the island here, we only have 3 or 4 ECMO machines. I was able to get the patient on the last ECMO. But that's just an example of what did we learn from here. I think we learned that we stayed, we waited too long. I think I learned that those people do not act like the regular ARDS. And I had to use different strategy that if somebody was telling me that, oh, I use PEEP 5 versus PEEP of 20 to oxygenate somebody in 70% in ARDS because they're fulfilling the Berlin definition of ARDS, I would tell him you're crazy. But that's what I learned. Okay, I know you probably can't see anything from that slide, but pretty much this is the European Society of Critical Intensive Care Medicine recommendation. And it pretty much talks of what we talked about, the phenotypes, L and H, and how to ventilate the patient using the low tidal volume, keep the driving pressure below 15. So what happens if your driving pressure above 15, reduce the tidal volume, prone. It really wouldn't tell you really much. And I think it's simplified. So let's start with our patients who come hypoxic. Nothing new really. We start the patient with the oxygen, the low flow system, the regular nasal cannulas or the oxy mask, 5-7 liters. When they start failing, we start using the higher flow systems, the non-rebreather masks, the Venturi masks, 15 liters. And when they keep progressing, of course, we start using the high flow nasal cannula, the non-invasive positive pressure ventilation. Here's the problem with this, and of course, everybody's using them and they consume a lot of oxygen. When we do this to the patients, put them in the high flow and non-invasive positive ventilation, are we preventing them from being ventilated, eventually going to mechanical ventilation? The answer might not be yes. The answer might be we're just buying time, but they might end up in mechanical ventilation. So if you look here, the high flow and the non-invasive ventilation have been used variably all over the world. There's mostly from retrospective cohorts, the ranges from 14 to 63%, while non-invasive from 11 to 56%. While those modalities might improve the oxygenation and the dyspnea score for the patient, there's really no good data that demonstrate that those modalities are successful at preventing progression to intubation. And I'm sure something that you saw yourself, those people are on it for a week or two, and they end up being intubated in the ICU. How about self-proning? We've been a lot of talk about it. We've been telling every patient before he is intubated, do the self-proning, try to self-proning. And I am an advocate for proning much back from when I was a fellow, 2003. We used to use it a lot. Even at that time, there was no mortality benefit. Till later on, you know, in 2015 or 14, I can't remember, when the studies start to show that no longer proning might help mortality. So we tell patients self-prone, and you might see some benefit of that. The sad part is it has not shown to really avert intubation. Again, from you might have seen it yourself. Self-prone improve. A lot of those people are obese and they cannot even self-prone and unfortunately end up intubation. I'm not saying don't do it. If the patient can tolerate it and if the patient can benefit from it, by all means do it. We don't know which one will benefit from it, and we don't know how long. In ARDS, we usually prone people 16, 18 hours. Patient who's not intubated, they probably can't do it more than a couple of hours. Timing of intubation, and we already talked about that. I think it remains a clinical decision, still controversial. There's a few small studies and retrospective studies that show if you do intubation early versus late, you might not affect the mortality really much. So the answer is, I don't know when to intubate a patient or what. Am I helping the patient or not? The ROX index, we talked about it. It's basically the SpO2 over FI2 ratio over the respiratory rate. So if you're above 4.8, 8 might be success and you're not gonna fail the high flow. And if it's below 3.85, consider intubation. I try to calculate that risk on a lot of people who are on high flow nasal cannula. And to be honest with you, if I follow it, I probably have to intubate like 80–90% of those people. There's some studies also that index might not be very accurate. All right, so back to the mechanical ventilatory support. How are we gonna do it? And I talked many times now about that. I do not agree, but again, that's personal opinion. So don't say, "Yep, we're gonna throw this ARDS network." You know, of course, your choice. But there is a lot of science. I'm not the only person. A lot of people like Marini, Gattinoni, those people who are some of the major minds in mechanical ventilation, they wrote this article. So mechanical ventilation depends on the time course of the disease and treatment approach. Again, not one head fits all. So before intubating these people, try to avoid patient self-induced lung injury. Again, I don't know how you're gonna avoid this. Tell the patient don't breathe 35 tell him not use negative pleural pressure of 15 or 20. So transpulmonary pressure, we're going to be very high. So yes, you can, maybe high flow nasal Kenya will reduce the air hunger, maybe non-invasive will reduce this. Again, during mechanical ventilation, if you look here, minimize the PEEP, especially in the L phenotype, the one that almost looks the X-ray and CTs looks pretty much normal because they don't benefit from PEEP. So minimize the PEEP. Try to adjust for acceptable blood gas. Of course, we do this. And here's the part I'm talking about. After intubation, minimize the pulmonary stress. Sometimes because those people are, their respiratory drive is very high, and I'm sure you saw that. You can't control them with regular sedation. They're always causing ventilator dysynchrony. I think our use of muscle relaxant paralytics all over the world has increased dramatically just because to put those people in having synchronization with the ventilator, so to prevent the patient's self-induced lung injury and the ventilator-induced lung injury. If it's type type L, the low, use lower PEEP, they just said below 10, use more liberal tidal volume to reduce the oxygen demand and consider prone position. And the rationale is the lower tidal volume are unnecessary, higher PEEP is ineffective, and actually can worsen the dead space and adversely redirects the blood flow. Now, if it's type H, now they recommend use higher PEEP, below 15, use lower tidal volume, implement prone position. And in type H, more closely behave and responds like our typical ARDS. So the question is, you're gonna ask, how do I know it's type L or type H? Well, there's multiple ways of knowing it. Of course, the X-ray and the CAT scans might give you an idea. I think you have to calculate the respiratory compliance, respiratory system compliance, the lung compliance alone if you can. And we'll talk about this. You have to calculate the dead space. Again, there's many ways of doing this. And you have to calculate the shunt fraction to know if my patient L or my phenotype is H. All right, so this is a pressure volume curve that I still love to do it. It's pretty easy. Now it's all over any mechanical ventilator, new generation that you're going to be using it. Of course, different how to do it on each ventilator, but this is an example of a patient. You can see that low inflection point or the opening point starts at very high pressure at 20. It becomes linear here, and we put a pause. And when you put the pause here, there is no increase in the volume, meaning this lung is not recruitable with a high volume. And if you look at the hysteresis, which is the difference between the inspiratory limb and the expiratory limb, this part here is very, very narrow. So what does this tell me? This patient is not going to benefit from recruitment maneuvers, is not going to benefit from high PEEP. Don't waste your time. If you put the patient on high PEEP, he's probably going to get worse. And I think that fits my patient that I talked about. If you look at the right side here, this is the patient, as you can see, when you start to increase the PEEP, the lung opens. And when you put a pause at the end of that pressure volume curve, the patient start to gain volume. It goes from, like, I think I can see exactly, but from 950 to over 1100. So he gains volume. And if you look at the hysteresis, marked difference between the inspiratory limb and the expiratory limb versus here. I think you can see the difference. So this patient will probably benefit from recruitment maneuvers and high PEEP strategy. Another way of doing it, I like to know, again, the respiratory system compliance. Sorry, I'm going to go back to that last slide because, of course, you can calculate the respiratory system compliance, which is the tidal volume over the pressure applied. If you have an esophageal balloon, like the next step, you can differentiate the lung compliance itself from the chest wall compliance. I like to use this esophageal balloon and the transpulmonary pressure. That's a separate subject, but look at it. This is the airway pressure. This is the flow. Am I late? We still good in time? Okay, sorry. I'm gonna try to wrap it quickly. And I try to use the inspiratory pressure below transpulmonary pressure 20 and adjust the PEEP to keep above 0. And again, there's no much studies in COVID about this, but it's coming from the regular ARDS. This, okay. This is a new strategy recently published, actually a couple of months ago by a Canadian group called Recruitment to Inflation Ratio. Very interesting. I never heard about it before, but it tells you how to set the PEEP. I put the video here. It's 2 minutes. I'm going to start from the beginning. So it goes very fast. We'll try to talk about it. So it's called recruitment to inflation ratio. So this patient on volume control, square wave form, totally passive, meaning paralyzed, rate of 26. He was in PEEP of 15. Now they're going to drop the rate to 8, just to prolong the expiration time. And they will drop the PEEP from 15 here down to 5 very quickly. And what they will do is see the tidal volume change. So see in the next slide, they will freeze the screen. I will do it again. So the tidal volume here was 470, but if you calculate this tidal volume, it would be 800 something. So they call that the tidal volume exhaled. So the difference of tidal volume between the difference of PEEP of 15 to 5, as you can see here, this is 812, this is 470. So the end expiratory lung volume, EELV, was 342. It gets complicated. It's not a very simple, actually, maneuver to do. Now they were going to try to measure the respiratory system compliance at the PEEP of 5. So they will do pressure volume curve and measure the respiratory system compliance, which here it said 28. And they did the pressure volume curves that we talk about. So without recruitment at the PEEP of 5, here the respiratory system compliance was 28. They were going to do the difference of Oh, okay. Sorry, the video basically went by fast, but we don't have much time. So I'm going to try to see where we stopped here. Okay. So they measured we said the respiratory system compliance at 10. They measured the expected EE end expiratory lung volume with the recruitment, came at 28. I know the math will be a little bit difficult. So they did the recruited volume was the N 342, the difference minus the 228 came to 62, and get the compliance of the recruited lung. So 62 over the delta PEEP of 10 came at 6.2 milliliter per centimeter water, and that's the compliance of the recruited lung. Now more math, they will divide this, the recruitment inflation ratio, which is the compliance of the compliance of the recruited lung over the compliance of the respiratory system at delta PEEP. So 6.2 of the recruited lung over 28 of the compliance of the low PEEP came at 0.22. And they came to the conclusion, according to some data, is if that ratio is below 0.5, this patient is low recruiter, and higher PEEP is probably not necessarily not going to be healthy. I left here the reference for you. You can read that article. Very interesting. Now, so I started thinking back in June. Okay, if this, because I'm old enough to be in the H1N1 influenza, and this patient actually acted very similar. normal compliance, high thrombi, high DVT-PE, and we cannot oxygenate those people. And what we did at that time, prone the patient, used APRV. So I tried to think, if the problem is perfusion, what can improve perfusion? And again, a lot of people did this. So we wrote this, basically it just was a letter, like a short communication. Maybe prone position would help. And so far the data are not robust, but it might help. How about APRV? Can I say this mode work better for COVID? And to be honest with you, I tried it a lot. I can't swear to you that it improves mortality or improves oxygenation, but something that a lot of people talked about, but there's no really good studies. Again, I left the reference for you here, you can read. So the prone position, so far, what we know is mostly coming from small cohort observation retrospective studies, probably some improvement of oxygenation. Some studies showing, yes, there might be mortality benefits, other might not. I still believe in it, and I think we should do it. Of course, it's a lot of resources, a lot of personnel, but I think we should do it. Now, when we come to our last resort, like my patient that I mentioned about is ECMO. When everything fails, ECMO is the last resort. Unfortunately, ECMO is not widely available, tertiary centers. So to transfer a patient miles away with a plane, or sometimes they end up dying. Now, the question is, does ECMO improve mortality in COVID and in regular ARDS? And there's really no convincing data about that. In COVID, there's no prospective studies, but in even ARDS, no convincing data. Of course, you have to deal with the complications of ARDS, of COVID. This is a case we published again last year, I think, of a COVID patient who survived, but here's the end result: lung fibrosis, cystic emphysematous changes, always come to the hospital with spontaneous pneumothorax. Those people, their rate of pneumothorax, so their spontaneous or on mechanical ventilation is very high than normal. Pulmonary embolism is almost 9 times more. And with that, I'm going to stop. I hope that was a little bit beneficial. Maybe it's more food for the thought, but with really no answers of how to ventilate the patient. Thank you for your time. Again, this is our society. Please join us. It's free. Tell us your opinion and share your thoughts. Thank you.
Okay, sorry. I'm in the same room as Dr. Daoud, so getting some feedback there. Sorry about that. Dr. Daoud, there was one question so far, and it was referring to the use of inhaled nitric oxide.
Yep.
So the question is, we have been using INO with some patients with COVID or on NIV. There have been mixed responses in SpO2 dependence on INO. Is there a place for this therapy in this pandemic, and should we utilize it more? And I know that some facilities don't have access to INO, others do. So I'm not sure your access to it.
That's actually a great question, and I didn't mention it. I wanted to add it in the slides, but I said I'm not going to talk about pharmacological therapy, but that's absolutely the adjuncts to mechanical ventilation. If you think about it, the problem with COVID, especially the low perfusion and the low VQ mismatch, the vaso and microthrombi, so vasodilating the arterioles, it makes great sense. So I actually, we don't have INO per se, but we have inhaled Flolan or prostacyclin, inhaled prostacyclin. And I actually used it in many patients. I used it inhaled, I used it systemic. I was kind of disappointed. It really never worked or as much as I was hoping for. Again, if you go back to the H1N1, we used a lot of inhaled nitric oxide. It didn't help, but physiologic, it makes much more sense. So maybe we used it at the time where we passed that L phenotype, and now we're in the problem with the consolidation as a problem. So I think it has a role, and if you have it, and you should try it. If it works, great. If it doesn't,
Thank you. I know I have seen it used at Kaiser where I do some call-in work, and they are using it on adults. But anecdotally, I'm not convinced it really was helping. So, and I think, you know, it's the mechanisms that it was approved for with the FDA, with PPHN, it's a different mechanism of the form of pulmonary hypertension. So it may not always work. I'm sorry, Bob, was there another question? Oh, there's a question in the Q&A. Let me look at that. Sorry about that. The question was, have you nebulized Flolan in patients? And can you talk more about that?
Yeah. Actually, matter of fact, the most common way I did it was continuous inhaled Flolan. Usually we start at the maximum dose, at least those are approved for ARDS, the 50 nanograms per kilogram per minute, continuous inhaled. I like that way because it doesn't affect the systemic circulation, so it's supposed to work more on the pulmonary circulation. Most of those people are in shock, and if I can't use it, you know, I tried it systemic too, but again, honestly, I had really not much very good response. If you look at the data from the regular ARDS about inhaled prostacyclins and inhaled nitric oxide, unfortunately, was very disappointing too. Yeah, so I use it. Of course, it depends on the ventilator you're using, according to the equipment. It might mess with the flows if you're not using, you know, a different specific device for it. So.
Thank you. There was one other question. It's asking about initial vent settings for COVID patients. Should you start with pressure control or APRV, or what is your preference, I guess, is what we're asking here.
Okay, that's a great question, and I hope I know the right answer, but I'm going to tell you my personal bias. I never, ever use volume control ventilation. Again, my personal bias, being called a heretic for not following the RDS network. And I have my reasons, and the synchronies that happens with it. Although if you're a believer and you want to use, you can achieve the same things with any ventilator mode, ASV, APRV, PRVC, whatever. I always use pressure control for many reasons. Again, improve oxygenation, less desynchrony, doesn't affect the work of the breathing of the patient. And I try to adjust the PEEP. I use APRV. I tried to use it early, and I used it in many patients. Again, the problem is this people, because of in COVID, those patients, the respiratory drive is so high to the point is like, we have to paralyze a lot of them. So if I put the patient on APRV while they're paralyzed, I kind of defeated the purpose of APRV with the, using their own, but I used it. I can't tell you that I saw miracles from it. Again, I used it in the H1N1, didn't see the miracles from it. My point is, I don't think the mode is the most important thing. I can tell you one mode will save a patient versus others. Because if we have one mode that saves patients, then there is no excuse not to use it, so.
You're listing more questions.
Okay.
Shoot.
What's the other question? I don't see it. The use of HFOV on COVID patients.
I am not aware of it at all. I haven't even read anything about high frequency oscillator. I think since those trials 4 or 5 years ago, kind of like killed the high frequency, I want to say. I don't agree with those trials again, because if you look at our history, especially in mechanical ventilation, we came like with some studies like, oh, proning, actually, if you look 20 years ago, proning doesn't improve mortality. We shouldn't prone. Now look at us. Proning is beneficial and safe. We should do it, PEEP, there is no PEEP difference, like all these trials. We shouldn't use, like, just use one sort of PEEP. Now it's like, no, high PEEP might help in those cases. So I wouldn't get high frequency off the table. I mean, it works in neonates and in kids, maybe it's us, we use it the wrong way. I don't have high frequency at the places I work with, but if I had it, trust me, I would have probably tried it.
I don't know if you agree with this, but what I'm hearing is use the ventilator and the modes that you're most familiar with and most comfortable with. And some places, if you do have access to oscillators and you're good at it, it might work. But as you mentioned, there was a couple of studies about 5 years ago that really devastated the use of high frequency oscillators in adults.
Yes.
It's still, there's a place for it in neonatal and pediatric where it started out. But it's really been, and I have a lot of issues. I think you do too with those studies. I don't think they were very conclusive myself, but a lot of people put a lot of faith in those, and oscillators have become almost extinct in the adult world nowadays.
Yeah, that's true.
Unfortunately,
Yeah,
I still think there's a place.
Yeah, we used to actually, during the H1N1, we were at that time in a big center in Cleveland, and we used to actually see who puts more people on high frequency oscillators, and they had their problems, but I thought they helped, in the people that you can't oxygenate and stuff like that. So.
All right, I think that about does it.
And we have a couple more. Yes, we have a couple more questions. There's one in the question and answer and one in the chat box from Stanley.
Oh, okay. Let's quickly. Did you ever try INO on patients before they are intubated? And then I'll look at the Q&A one.
Yeah, I honestly, I haven't personally. I know a lot of people, especially early in the pandemic, were so scared of the continuous inhaled medications, or any, actually even the bronchodilators in the non-intubated patients. We used to try to feel better when we use it in negative pressure rooms. But of course, as the pandemic grows and we don't have negative pressure rooms, everybody's scared to do it. But I haven't tried it personally.
And the last question is, how many days of proning is beneficial? And I think they're asking, it says, when do you say it's not working? So when do you give up on proning?
Yeah. Excellent question. I hope, I wish that I know the answer. I think we still do it in a clinical way. Like, I prone the patient, and I left most of the people or the studies, at least in ARDS, limit proning to 16 hours. I have to say that I had people, when I prone them, and proning takes a long time to help. When I finally got these people oxygenating like 88, 85%, it's already 16 hours. I say, you know what, I'm not taking a chance. I leave them 48 hours even proned, and I did that. Of course, the patient looks horrible and swollen, but you know what? It happened actually last week. We did this 48 hours. I left them 48 hours. And as soon as we did supine to put dialysis catheter, wasn't even an hour before the patient started going down. And I put the catheter, proned them again for another 24 hours. I think once you achieve what you're looking for in proning, by reducing the FiO2, reducing the pressures, and you put them supine and see what happens. If they're staying the course, staying good, great. But if you start, my FiO2 is going up again, well, you keep doing it. But there's no really strict answer to that. Sorry.
I think my watch is saying we need to stop, but I'm sure Dr. Dode would be happy to answer questions if you contact him, or you can contact me later, and he may be around for a little while.
My email is,
I think we need to take a quick break. Gary, do you agree? And then we'll get ready for our last speaker.
Yes. So let's